Whoa, did you take something down? I just lost your PowerPoint.
Well, I'm uploading a new one if that's okay.
Oh, okay.
If not, I can go off that old one. I just changed it slightly this morning.
I just want to make sure you'd done
You
something.
talk as well?
As well?
Huh?
Yes.
What time are you supposed to be giving a talk?
I thought noon.
So am I. How long is your talk?
It's an hour. They double book us.
Yeah, they double booked us.
How are you?
I'm good.
You've got them both down for noon?
You got two people talking at noon for an hour.
No.
Yeah.
Did I schedule two? Okay, yours is,
I was wondering why there's two different.
yours is cardiac?
Mm-hmm.
And
I'm
yours-
talking about anticoagulants.
Okay. She was supposed to have yours at 1:30.
So there is two talks today.
There is two talks today. You're 12 and you're supposed to be 1:30.
Okay. All right, well.
Is it working on? we're full-
I'm seeing it everywhere, but I'm looking on the website and it's not coming up.
It showed me a few minutes ago.
I know, it's like, for some reason, it's like falling behind or something. Let me try one other thing. I'm gonna shut it down. I'm gonna try it. If it doesn't work, we're just gonna have to, I've taken everything down. We're just gonna have to let it go and see where it goes.
Okay.
It's like it's lagging way behind.
Those will get it recorded.
I mean, like way behind.
Okay.
And I don't know if it's because I'm just not getting the good thing here. I'm getting everything here now. Everything's working here. Let me, I want to try to swap this out one more time and see what happens.
All right, well, I guess I'll come back at 1:30.
You're welcome to sit in here if you, or if you need an office, we've got an office right down here.
That's okay. I'll just, I got. So I do my part. All right.
He loaded another PowerPoint on
Okay,
there. So we'll need to bring the old one back up.
okay.
Come on, come on.
I'll be in this place here.
Yes,
All right.
you will.
Best of luck.
Thanks.
See you.
Hey, ladies. Hey. Grab you a handout, sign in, and if you'll sit over here on this side for me.
We like to have a live audience for you,
I
so.
like the cheering squad.
Yes, exactly.
It's kind of hard to just talk to the camera.
It is, it is.
Can you go ahead, I don't have any PowerPoint up there.
Okay. He took down that one.
He did something and took it down. He,
Okay.
see, it's like it keeps coming back to the whole video for some reason. I don't know why.
Okay, I have it pulled up. Can you see it?
Yes,
We're good on that?
I think. The problem is I keep having to shut it down and bring it back up, but it's going back, every time I try to do it, it's going back to when I first started rolling on it. So it's going way back, like 15 minutes back. So it may actually start 15 minutes late for it to catch up. And I don't know why. I have no idea why.
They will call me. So.
If somebody asks, just say it's coming up late.
Yeah.
I mean, I've got you on everything. I can see everything here, but on the website.
Okay.
Because it's reverting back, and every time I had to adjust the camera, and it shows that. And I don't know why.
We've got you pulled up, so he will get you started here in
We'll just start on normal time, but it may not show up on the website for another 10, 15 minutes.
That's fine. Don't worry, they'll contact me. If you'll, when you get ready to present, just take my answer.
Roger, Michael. Is there anyone that could just take me down the ER? Just like to meet some of the other ER doctors here.
I can take it down.
That'd
She can
be-
take it down there. Yeah. Thank you. Yeah, no problem.
It's not a big deal if it doesn't work out, but,
If you'll put that in your pocket,
okay.
just make sure that while you're doing your presentation, don't put your hand in that pocket, because if
Got
you
it.
start tapping around, it'll,
People won't like that.
yeah, it'll start making a tapping noise on the mic.
Donald, key you up. I'm gonna go in the office and see if I can pull it up. No.
Like I said, it's gonna start, he's not gonna be on there. It looks like it's falling off 15 minutes behind.
I'm wrong. I admit that I was wrong. Hey, Dr. Russian, I've been talking you up to the ladies here. So I was like, he's gonna be excellent. You're gonna love
Uh-oh.
it. You don't know me, but I know you. I worked with you at UAB, but
You look very familiar. Is this,
you're a lot skinnier and a lot shorter hair.
is this on or do I need to turn on before I start?
You don't do anything to that. Don't touch anything on that one. Make sure you didn't touch anything on it.
I did.
Yeah, you'll be good to go.
And then are people able to see the mouse on the screen if I move it or not?
Just touch screen, you should be able to touch it and actually
Yeah, can you see it moving?
make it, hang on one second. I'll get a delay in this one.
It's fine if it does. I just want to know beforehand.
Yeah, there's a way you can, it should be set up to where it's a touch screen where you can move your finger on it and it'll show back up on there. Let me text her and tell her that it's not.
I don't know what kind of grade this is, but.
I don't know if you can see that at all.
Oh, there it goes, now I can see it.
Okay,
So but you'll see it, yeah, just kind of, you'll need to pull it.
Got it.
off. So, or it'll just sit there on your thing.
I see it. So right now, I guess you cannot see it, but here you can probably see it.
I can see that now, yeah.
Yeah,
When
then-
you pull it off, you can't see it.
Great.
Hi there. My name is Will Rush, and I just want to say what an honor it is to actually be here. I am the medical director for the Alabama Poison Information Center. I also work as a ER physician over at UAB in the emergency department there. I also run the Office of Medical Toxicology. And I had such a great time being back here in February, and what an honor it is to be back here to talk to you guys again. My job is actually make something as mundane sounding as cardiovascular toxins, and hopefully sort of impart with you guys some of the excitement, because this is really what gets toxicologists excited. Some of our most dangerous or poisons that we see, but also I think some of our more interesting and very challenging poisons too, that from a toxicologist standpoint, sort of really what gets us up, get going in the morning. So just to start off, unfortunately, not for a lack of trying, I have no financial disclosures to impart to you guys. And really, the purpose of this talk is threefold. It's to explore sort of the different classes of cardiovascular toxins and really break it down. You know, the name cardiovascular toxins, I think, sounds sort of ominous and scary. But when we talk about sort of different classes of drugs, there are certain classes that we care a lot about and certain classes of drugs that when people either take too much, either by accident or in a suicide attempt, you know, they tend to do pretty well. And we'll sort of discuss which ones we really need to worry about. Sort of discuss the different pathophysiology, as well as some of the new treatments that are out there, particularly when it comes to treating calcium channel blockers and beta blockers. And so we talk about cardiovascular toxin. You know, again, toxicologists like to go for the big sexy drugs, which are the calcium channel blockers and the beta blockers. But there are a lot of other drugs that are out there that actually have a lot of cardiovascular effects. One of them is actually Visine, which has tetrahydrolazine in it. Now, poison centers about 10 years ago got a lot of experience with Visine toxicity because in that movie Wedding Crashers, I don't know if anyone remembers it, but Owen Wilson actually dumps a whole bottle of Visine in his protagonist's drink. And in that movie, you actually see the protagonist has terrible GI effects. He's having bad diarrhea. He is on the toilet. And so because of that movie, as a lot of adolescent males thought this would be a fun thing to do to their colleagues and at school and as a prank. Unfortunately, tetrahydrolazine, which is what's in Visine, when you use it peripherally, acts as an alpha-1 agonist. So it hits alpha-1 receptors, causes localized arterial constriction, and that's what dries up sort of the arteries in our eyes and gives us dry eyes. Unfortunately, when you ingest it, it acts as an alpha-2 agonist, something very similar to clonidine. So all these adolescent males, instead of getting the diarrhea that we thought that, or they thought that they were going to give to their fellow classmates, instead start showing up to emergency departments with pretty impressive lethargy, which is what clonidine can do. Is one of the reasons why it's used as ADHD, but also hypotension and bradycardia. And a couple of these adolescents end up having to go on vasopressors as well. And then there's a lot of plants also out there that have cardiovascular toxins. So probably the favorite plant of toxicologists is a foxglove, which has digoxin in it. But a lot of other plants out there, particularly internationally, have cardiac steroids in it. This is yellow oleander, which has oleandrin in it. It's a toxin very similar to digoxin. So in acute ingestion of this plant, whether someone's trying to, again, hurt themselves or they're just foraging, trying to make a salad, you expect them to come in with a digoxin-like poisoning, hypotension, bradycardia, hyperkalemia. And probably my least favorite cardiovascular toxin, just because I find it personally absolutely disgusting to eat, but is true licorice. Now this isn't Twizzlers, but this is actual licorice, which has something called glazuric acid in it. And glazuric acid actually prevents the breakdown of mineralocorticoids. So people that have actually underlying hypertension really should not be eating true licorice just because it can actually worsen their hypertension and can cause a lot of refractory hypertension. Now, Twizzlers is sort of fake licorice, doesn't truly have glazuric acid in it. So I used to say that, you know, it's fine to go ahead and eat all Twizzlers you want, but probably with the sugar content is people with hypertension should also avoid Twizzlers as well. Now, the focus of this talk, or the bulk of it, is really going to be on a patient that I had the opportunity to take care of about 9 years ago. And so the lab values, the EKGs, the chest x-rays, these are all from this one person. These are not Google images, and really use it as a backbone to frame this talk. So this is a 21-year-old female, was actually brought into the emergency department, and she was a prisoner, and shows up hypotensive, blood pressure 70/40, bradycardic, bradypnea, her respiratory rate's only 8. You know, a lot of things that toxicologists will look for, particularly overdose patients, is sort of the health of the autonomic nervous system. So for us, it's really important to note that her pupils were mid-size, that she did not have increased deep tendon reflexes, and she was a little bit diaphoretic. This is her initial laboratory work, and there's a couple things on here that I think are notable, at least to point out. Shows up already hypokalemic. It's interesting her glucose is 241. At this point, we didn't know about her past medical history and didn't know if she had a history of diabetes or not. Certainly has a pretty impressive leukocytosis. And this is her initial 12-lead EKG. Now, I don't know about you guys, but I'm a firm believer it's really hard to tell a rhythm just based off of a 12-lead EKG. It's much better to get a rhythm strip. But I think just at least initially looking at this 12-lead is we can all agree this is definitely abnormal for a 21-year-old female that we are at least surmising is otherwise healthy. First of all, the QRS is widened, it's slow. And so toxicologists, again, when we get an unknown drug ingestion, we always go back to what's the toxidrome. And we're not very creative people, so we call this the cardiovascular toxidrome. Just saying, hey, there's something in there that's actually impeding sort of both the chronotropy and the inotropy of the heart, the ability of the heart to how fast it's beating and how hard it's beating. And so when we talk about what can really go into a cardiovascular toxidrome, there's a couple drugs that we break it down. Now there's calcium channel antagonists or calcium channel blockers. And those really fall into two different categories, the dihydropyridines, such as amlodipine, nicardipine, nizolidipine, as well as the non-dihydropyridines, which are diltiazem and verapamil. There's beta blockers, there's cardiac steroids such as digoxin and Olander, which is in that plant, yellow Olander I was just talking about falls in. Then there's alpha-2 agonist. So this is going to be clonidine. It's also unfortunately still going to be tetrahydrolazine, which we just talked about. And also Afrin has oxymetazoline in it. So if someone actually ingests a bottle of Afrin, we would also expect them to have a clonidine-like a picture, hypotension, bradycardia, and lethargy. And then there's some vasodilators. So as we're talking about ACE inhibitors, ARBs, some nitrates out there. And this is sort of just a blatant plug for the Poison Center, is that when we talk about, look at national Poison Center data, is cardiovascular drugs are actually fairly high that gets reported. And what's interesting is that the Poison Centers each year are getting more and more calls about cardiovascular drugs and the cardiovascular toxidrome. And again, the cardiovascular toxidrome is hypotension, bradycardia from suspected drug poisoning. And it's not that we think that these drugs are being prescribed more, it's sort of the nature of the Poison Center is changing. You know, 30 years ago, Poison Centers were really a pediatric triage hotline. And now more and more, as I think healthcare institutions are recognizing our utility in managing particularly some of these really complicated toxidromes, which is certainly what these cardiovascular drugs can cause. So again, the alpha-2 agonist, this is going to be clonidine, someone ingests a whole bunch of clonidine. We expect them to come in hypotension. You know, what the alpha-2 drugs do, well, it hits the negative feedback on your sympathetic nervous system. So you lose that sympathetic tone to the heart, the parasympathetic tone predominates, you become bradycardia. You also lose that sympathetic tone in your arteries, causing arterial dilation and hypotension. And inside your CNS tissue, as clonidine hits a receptor called your imidazoline receptors, and can cause sort of a lot of sedation, lethargy. And when we talk about alpha-2 agonists, again, it's not just clonidine. There's some ADHD drugs out there, but again, always remember Afrin and Visine. If someone ingests these, expect them to come in with a sort of a clonidine-like a picture. And then there's our cardiac steroids, such as digoxin and Olander. Predominantly these inhibit the sodium-potassium ATPase. What that causes is hypotension, bradydysrhythmias very frequently, and the hallmark for this is really going to be hyperkalemia. So, so much we do is just pattern recognition. If I see, someone that at least gave me the history that they're out there foraging in the woods for food, and they come in hypotensive, bradycardic, and they have an unexplained hyperkalemia, without any sort of associated renal dysfunction, it's just pattern recognition that's going to get us thinking about, could this be a cardiac steroid? And it's a fairly easy thing to check because you can order digoxin level for confirmatory or for confirmation. And then there's the vasodilators. These are going to be your ACE inhibitors, your ARBs. Now, thankfully is, even with massive ingestion, is people tend to tolerate ACE inhibitor fairly well. It's pretty rare, even with a very large ingestion. We're talking about an entire bottle for anyone to get hypotensive. And if they do, it's usually we just treat it with fluids and their blood pressure bounces right back. Sort of some of the more long-term issues you can see with ACE inhibitors and ARBs, such as renal dysfunction, electrolyte changes, that's not really something that we actually see with a single acute ingestion. So it's really just monitoring their blood pressure and monitoring for signs of hypotension. Now when we get to, again, is sort of the big guns in the cardiovascular toxidrome, is this is really, this is pure self-promotion for me, but this is really where I think the Poison Center can help out a lot. Because managing these calcium channel blockers, these beta blockers we're going to talk about, can get pretty challenging. And so to try to illustrate this is I actually created a PowerPoint animation. So I know who's ever looking, if they have any of the printed out handout slides, this might be a little bit confusing. And if anyone has ever tried to make a PowerPoint animation, you'll understand how unbelievably difficult it is. So I made this animation this one time, and I have sworn I will never make another PowerPoint animation again. And so I know I don't really have much of a live audience, but I always encourage people is spontaneous applause during this PowerPoint animation is highly encouraged. But let's just talk about, how's that cardiac myocyte working? And so what happens? Well, you get a circulating beta agonist, and endogenally this is usually epinephrine. Hits a beta-1 receptor, activates G protein second meeting system. And I know this is usually when I start losing people, so I'm going to try to keep this short and try to make it a little bit exciting, but also show why we care so much about it. So the G protein goes around as other second messaging, hits your cyclic AMP. Cyclic AMP does some other messaging, ultimately ends up opening up your L-type calcium channels. Calcium comes into the cell. This calcium still acts as a messenger, goes to your sarcoplasmic reticulum, and causes a lot of calcium release. Now this calcium is released, binds troponin, and particularly in the myocytes in the left ventricle, this is what ventricular systole is, or active ventricular contraction. And just to go ahead and throw some ideas of some pathologies out there, so if you get a beta blocker around, beta blockers, again, are obviously going to block beta-1 receptors and prevent this activation of the G protein second messaging system. And before we sort of go into some of the evidence, I did just want to go ahead and introduce the idea of glucagon here, because I think it's much easier to see on a PowerPoint animation how glucagon works rather than talk about all these multiple second messaging. So the whole point about glucagon is it hits these glucagon receptors and directly stimulates cyclic AMP. Cyclic AMP, again, will then go around, open up those L-type calcium channels, allowing calcium to release, and ventricular systole will still go on. But one of the ideas we're going to talk about here with some of the literature is, why is glucagon pretty effective for beta blocker toxicity, but less effective for calcium channel blocker toxicity? And again, it has to do that calcium channels are inhibiting a channel that's much farther downstream than where glucagon is able to have an effect. So even if you pump glucagon, increase your cyclic AMP, if you have significant blocking on those L-type calcium channels, particularly with non-dihydropyridine like verapamil and diltiazem, is you're still going to be unable to allow much calcium to go into the cell, and then thereby really inhibiting ventricular systole. Now, as of reviewing cardiac physiology is not as exciting enough for people, I think it is beneficial to talk about cardiac toxidromes and unfortunately review the cardiac action potential. And this is where the residents have to rotate with me. I immediately see them pulling out their phone, but I promise you there's actually a whole point that we're going to go through and do this. And so what's happening in phase 0 of the cardiac action potential? Well, this is actually when sodium opens up, and so sodium goes into the cardiac myocyte, and what happens is the cell's depolarized. And then in phase 2, these cardiac sodium channels close up, and now this is where actually calcium comes back through that L-type calcium channel. So calcium's coming in, and it's coming in at the same electrical rate that these potassium efflux channels open up, kicking potassium out. So calcium's coming in, potassium's going out, and this is phase 2 of the cardiac action potential. And this is on your EKG lead, is really what's delaying between the S and the T wave. And what's really important about this is phase 2, is this is when those L-type calcium channels are opening up, causing more calcium release from the sarcoplasmic reticulum, bonding troponin and causing contraction. So phase 2 is really direct ventricular systole. What happens in phase 3? Well, ventricular systole is over, these L-type calcium channels close, more of these potassium efflux channels open up, and so what happens is they're kicking out more positive ions, so the cell becomes more negative and repolarizes, and this is what your T wave is. In phase 4 of the cardiac action potential is your sodium-potassium ATPases open up. It really just resets the whole process. So what it does is all that sodium that came in, it pumps it back out, and all that potassium that went out, it pumps it back in, actively spins ATP, so the whole cycle is repeated. Now, why is that important? Well, when you think about particular really dangerous cardiac pathogens, if you will, what are the big players that cause the cardiac toxidrome, is I think it's actually helpful to think about what stage of the cardiac action potential are they inhibiting. Something that's not really germane to this talk, but a phase 0 toxin. This is actually going to be your tricyclic antidepressants. Tricyclic antidepressants, if you know anything about them, is they cause sort of all their cardiac dysfunction by blocking the cardiac sodium channel. What this does is it delays phase 0, and since your R wave is a function of phase 0, your R wave is actually delayed, and that's actually why you get QRS prolongation with tricyclic antidepressants and can get some cardiac dysfunction. In phase 2 toxicity, this is where calcium channel blockers come into play. And what happens is because in phase 2 is my calcium channel blockers are directly inhibiting these L-type calcium channels. And if you think about it, if phase 2 is a function of ventricular systole and calcium channel blockers are directly inhibiting my L-type, inhibiting phase 2, the cardiac action potential, really I think it emphasizes the fact that calcium channel blockers can be very strong negative inotropes. That in addition to causing bradycardia, is they are really, particularly in toxicity, inhibiting the ability of that cell to squeeze and inhibiting the ability of ventricular systole. And so we think about calcium channel blockers. This is not why we focus, yes, they do cause some bradydysrhythmias, but they are such potent negative inotropes. And we talk about the treatment for calcium channel blockers. That's why we focus so much on improving inotropy rather than improving the heart rate with calcium channel blockers. What are phase 3 toxins? Sort of joke about this. What is not a phase 3 toxin at this point? Because this is actually all these drugs that cause QT prolongation, your antipsychotics, ondansetron, your macrolides, your fluoroquinolones. At this point, I think we're going to find out that water pretty soon causes QT prolongation. But how does it cause QT prolongation? Well, it prevents these potassium efflux channels. So this delays phase 3, and this is actually why your T wave is now delayed, since the T wave is a function of phase 3. And what's sort of the fourth action potential? This is where your cardiac steroids come into play. If we just say that the fourth stage of the cardiac action potential is that sodium potassium working, again, this is right where digoxin's going in. And so digoxin is a direct phase 4 toxin. And so it's almost like go around the world, and this time it's go around the cardiac action potential. Because we talked about tricyclic antidepressants, we talked about calcium channel blockers, we talked about all these drugs that cause QT prolongation, we talked about digoxin. And I purposely left a class of drugs out, and that's beta blockers. And the reason for that, and the whole point of this exercise, is really to emphasize why calcium channel blockers can be so much more dangerous than beta blockers. Because if anything, your beta blockers, particularly when we talk about beta blockers, we're talking about specifically drugs that antagonize or block beta 1, is a really indirect toxin. Your cardiac myocyte is still functioning, but that role of that beta 1 activity, activating that G protein, is really designed to augment the strength of the cardiac myocyte, to really increase inotropy. And so as we get older, we become a lot more reliant on this beta 1, to maintain cardiac function. But when you think about beta blocker toxicity, particularly when you're thinking about its ability to act as a negative inotrope, it's always going to be an indirect toxin, whereas calcium channel blockers are a direct phase 2 negative inotrope directly inhibiting ventricular systole. Also, one of the reasons too I think that pediatric patients tend to tolerate beta blockers a lot better than adult patients, just because they're not nearly as reliant on that beta 1 system to really augment cellular myocyte function. So let's talk about specifically some beta blockers that I think are notable to mention, because anytime you read a review article, there are certain things that review articles, I think, just copy and paste forward. And so we're going to delve just into a little bit about what some of the literature here. So we talk about bradycardia is one of the roles, or one of the things we always talk about with beta blockers specifically, is it depresses the activity of the SA in the AV node. That's going to be more important when we talk about calcium channel blockers. But in beta blocker toxicity, that SA node, which is firing my electrical impulse, and the AV node, which is allowing my atrial impulse to be conducted to my ventricles, it's still working, it's just being slowed down by beta blocker toxicity. So we talk about the rhythm that you see in beta blocker. Yes, it's a bradydysrhythmia, but it's almost always sinus bradycardia. And we're going to contrast that in a little bit with calcium channel blockers. And so you can get some hypotension, you can get some decreased inotropy. Again, this is not anywhere near significant as we would expect really with calcium channel antagonists. And a lot of review articles will talk about you can get some hypoglycemia with beta blockers. Usually that can happen in pediatric patients. Usually the time is we actually see sort of euglycemia. The glucose is actually where we would expect it to be. Now this is a very busy slide, and it's purposely busy, but it's just worth mentioning because every time, if you ever read a review article or up to date about beta blockers, it's always going to talk about a couple specific ones, and one of them is etenol. And the reason they always talk about etenol is because it's supposed to be the beta blocker that you can actually dialyze off. Well, as of 2015, this is the sum of all the international.
Sorry, I couldn't hear.
This is the sum of all of the international literature on beta blocker toxicity. And what's interesting is these 5 cases here, these are all case reports. And only one of these case reports actually looked at extracorporeal removal of etenol. And what was really interesting is in the only paper that actually checked sort of etenol levels when they were looking at extracorporeal removal is they did hemodialysis. I don't know about you guys, but if I have a really sick etenol patient, we're going to be using something like CRT, which we suspect is not going to be able to pull off etenol nearly as efficacious as hemodialysis. And so the point of this slide is just if you're ever reading a review article about etenol, yes, we would still consider doing dialysis really with CRT. That being said, is if you read a review article and it says, hey, immediately call nephrology for hemodialysis, that evidence is not nearly as robust. Now, conversely, when we talk about propranolol, of all the beta blockers, this propranolol tends to be by far the most dangerous. Because in addition to your beta blocker toxicity, propranolol is just a really dirty drug. It causes the blood-brain barrier, causes a lot of sedation. It prevents activation of your thyroid hormones. It also acts as a phase 0 toxin. It will also block your cardiac sodium channels. And so in addition to beta blocker toxicity, is you can also get QRS prolongation, something that's very similar to tricyclic antidepressants. And so if you see actually a propranolol overdose that's having QRS prolongation that's unexplained, is we would also treat this in addition to treating the beta blocker toxicity, but treat it very similar to a tricyclic antidepressant, really by using systemic alkalization, really for cardiac protection. And the evidence for this is way more robust. These are actually, I pulled these 3 studies out from the 80s and 90s and 2000s. These are actual cellular animal models that I think really support the idea that yes, when you read about propranolol saying that it can also cause QRS prolongation, that evidence is way more robust than when you're reading a review article and talks about immediately call nephrology to dialyze off etenol. And so with the calcium channel blockers, switching gear a little bit, mentioned these can be a lot more dangerous, but they're not all the same because we talk about the dihydropyridines and the non-dihydropyridines. The non-dihydropyridines, which are verapamil and diltiazem, tend to be a lot more dangerous because they are directly inhibiting the L-type calcium channel on the cardiac myocytes. Now, the dihydropyridines preferentially will block the L-type calcium channels on your arteries. And so when we talk about the dihydropyridines, which amlodipine, which is also Norvasc, is sort of the flagship drug of that class, is it tends to actually cause severe arterial dilation. And then you can actually see some reflex tachycardia. Now you do have to be a little bit careful with the dihydropyridines, again, such as amlodipine, because if you take enough of amlodipine, it's going to start losing specificity. It doesn't care which L-type calcium channel it's inhibiting, and it's going to start blocking the L-type calcium channels of your heart. And so just because someone overdoses on amlodipine we're definitely now in the woods as unfortunately amlodipine still causes or carries a very high mortality and morbidity just because of its sort of ability to act as a central acting calcium channel antagonist as well. And so when we talk about the non-dihydropyridines is, let's think about what kind of rhythm that they can cause. And again, this is really diltiazem and verapamil. I mentioned with the beta blockers, we expect to see sinus bradycardia. That is not actually the case when it comes to the centrally acting calcium channel antagonist. And the reason for that is because your SA node, where your electrical stimuli is produced, and your AV node, which again transmits atrial stimuli to ventricular conducting system, these are also both dependent on L-type calcium channels. And again, here is a funny current that I know I learned about it in medical school and thought I would never ever talk about again, and yet here I am talking to you guys about it. But what does this mean? Well, when you get calcium channel blockers, again, that are really acting on the heart, as we talk about bradydysrhythmias, but it's rarely a sinus bradycardia because often either the SA node is taken out or the AV node is taken out, or very often both the SA and the AV nodes are taken out. And so if you read about sort of classic calcium channel rhythms, is usually what we expect is actually a ventricular escape rhythm, where you get sort of a low ventricular escape rhythm, usually in the His-Purkinje cells. And so the rate tends to be a junctional escape rhythm that usually has some kind of QRS prolongation, and because it's coming from your ventricles, the rate is almost always in the 40s. And so going back, this is that 22-year-old's EKG. I'm just bringing it back up here again. And what's interesting about her is if you actually trace out this rhythm, she's in a complete AV nodal block. And so her SA node here is working, but our AV node has been taken completely out. And again, so we're getting a lower escape rhythm. That's why she actually has a ventricular rate here in the 40s. And so when you're trying to differentiate between, in the cardiac toxidrome, between a beta blocker and a calcium channel blockers, is frequently one of the things I'll ask about, particularly on the phone, if we're looking at the bedside, is what's the rhythm? Again, beta blockers expect to be sinus bradycardia, with calcium channel blockers, particularly with central pathophysiology, expected to be a non-sinus rhythm. And so this is actually, again, her chest X-ray. This is that 22-year-old female. She showed up, and again, I like this image because this ends up being a verapamil overdose, a non-dihydropyridine toxin. And I like this picture because I kept talking about, what does it mean to be a phase 2 toxin, directly inhibiting ventricular systole. And I think this chest X-ray just really gives you a good sort of visual representation of that, because a 22-year-old should not have this chest X-ray. They should not have this degree of cardiomegaly, nor this sort of profound pulmonary edema. And why are they having that? Well, that verapamil, again, is inhibiting ventricular systole, and she's really going into direct sort of cardiovascular collapse and really presenting now with a toxidrome that's very akin to cardiogenic shock. And so, again, our standard diagnostic studies, let's go into some treatment here. Well, activated charcoal, if someone ingests a whole bunch of beta blockers or calcium channel blockers and they come in with the first hour, is absolutely go ahead and give them just activated charcoal. Now, some of the beta blockers like Toprol XL, which is Metoprolol XL, as well as diltiazem, comes in extended release formulations. And so if you get someone that comes in and they ingest someone in the extended release formulation, even if you're 4 to 5 hours out, as long as they're awake and protecting their airway, we would still consider giving activated charcoal. Something else you can also consider, particularly if you have one of these extended release formulations, is doing whole bowel irrigation. We talk a lot about doing whole bowel irrigation in toxicology, and when you put in a slide like this, I think it makes a lot more sense than it does in the real world. Because very likely is this patient, if you have a really sick calcium channel blocker, their hemodynamics are just terrible. And it's very hard to put someone on whole bowel irrigation and cause just sort of profound GI loss when someone is that unstable as well. So it's easy to talk about. If you have a stable-ish patient that ingested a extended release calcium channel blocker, as I would consider doing whole bowel irrigation. I think the other big side effect besides just the terrible GI loss is your nurses just absolutely hate you. Because when you talk about toxicology literature, is really what's the endpoint where you're really titrating that Go Lightly solution to clear rectal effluents. And again, it's something that's very easy for me to say in actuality, I'm really thinking, as I'm about to sort of enlist my nursing colleagues into helping me out, and we're about to start a bunch of different drips, do I really want to anger them right at the get-go by starting whole bowel irrigation? So something I think that makes a lot more sense to talk about sort of in the abstract, but in actuality, it's not something that actually I end up recommending that much. And specific antidotes, well, very often beta blockers, calcium channel blockers come in with bradycardia, bradydysarrhythmias, and very frequently, as you know, we're all trained, a first-line treatment is give atropine, sort of our standard ACLS training for that. And there's actually a fair amount of studies on there saying you're not going to hurt anyone by giving atropine, but I would not expect to see a sustained improvement in hemodynamics. Usually the heart rate will go up, there's not much improvement of the blood pressure, and that transient improvement in the heart rate usually tends to be short-lived. So what we say with atropine, it's fine to try it, you're not going to hurt the patient, but I would not expect that to be the definitive treatment. And this plant right here, by the way, this is a deadly nightshade. I did pull this one off the internet. And a deadly nightshade is actually full of atropine. I just like sort of saying the name deadly nightshade as many times during a talk. And so calcium, and this is really my first go-to sort of antidote, if you will, when it comes to sort of the cardiovascular toxins. And calcium works really well, I think, for both beta blocker toxicity and calcium channel blocker toxicity, because all you're doing is just augmenting that amount of calcium that's going to the L-type calcium channel, and then allowing for increased ionotropy with your troponins. And there's actually been multiple animal models out there that have showed improvement with giving calcium with both beta blockers as well as calcium channel blockers. Another benefit to using calcium is that it's very well tolerated. There's not much side effects. I do find, particularly when I use calcium gluconate, is I will see an improvement of the hemodynamics. The blood pressure can improve. Again, it's pretty short-lived, usually lasts about 45 minutes to an hour. So if you do see an improvement with calcium, just expect that you may have to push it again in an hour, or this is something that when I treat these at the bedside, as I talk to my pharmacy colleagues, and we actually get a calcium infusion going and just trend serial ionized calcium levels. So glucagon, I sort of already touched base on this earlier. I mentioned that it works, I think, works really well with beta blocker toxicity, less so well with calcium channel blockers. And again, the way that glucagon works is it does increase cyclic AMP. There is some weak evidence for it in calcium channel blockers. However, in the canine models that we actually, I know these are hard slides to read, but I think everyone has these in their handouts, is if you look at animal models, there's a much more sustained improvement in hemodynamics when using glucagon for beta blocker toxicity than calcium channel blockers. And the problem with glucagon, one of the reasons it's not my first go-to drug, is that if you've ever given it, and we're giving it at 5 milligrams, this is really 5 times the dose we'd give for, say, a food impaction, is it tends to cause a lot of severe nausea and vomiting. So if you're ever getting to someone, particularly someone's already a bit sedate, may not be protecting their airway, just know if you push 5 milligrams, they're very likely going to vomit, and they're going to be at high risk of aspiration. So if they don't have a definitive airway already, this is something I have my suction catheter hooked up. I personally pre-treat with Zofran. There's never been any evidence that shows that it works. It does just make me feel a lot better, like I'm doing something with it. And then if you do see an improvement with glucagon, is then you can put someone on a glucagon infusion. Now, unfortunately, most hospitals just don't carry that much glucagon. And so with the whole bowel irrigation, as I mentioned, that my nursing colleagues really dislike it. Glucagon is, man, the pharmacy techs really dislike it because they end up having to go to these Omnicells and these Pyxis on every single unit, pulling the glucagon out, bringing it back down to central pharmacy, trying to create infusion. And usually most hospitals only have enough glucagon to go for a couple of hours. That being said, is if you do see an improvement, particularly with beta blockers, is I'll go ahead and put someone on a glucagon infusion. And the infusion tends to be a lot better tolerated than that initial 5 milligram bolus that we'll give. And what about vasopressors? And this is really where it gets to sort of the controversy, particularly in the toxicology world, about how to treat these. Because the toxicology world is actually a very small world. There's only about 410 of us in the United States. And I think when you get a group of people that are socially as awkward as we are, and you have a lot of people with a lot of big egos, this is where tensions start to flare. Because the Arizona Toxicology Center, they actually run their own ICU, they say, hey, you guys are doing all these crazy antidotes. We just put all these people on high-dose vasopressors and had 100% survivability. But what's really interesting, you read their study that this was, I believe, published in 2014 in the Annals of Emergency Medicine, is this is really just a case series of about 46 patients. They were putting their patients on exceptionally high doses of vasopressors, really sort of get them through it. And they reported that 5 of their patients had ischemic complications. No patient had dead gut, no patient lost extremity, but they did have ATN, and renal dysfunction was by far their most common complication. I think they did have 2 patients that had to be put on hemodialysis, at least temporarily. Now, on the other side is the Minnesota group. And so in the tox world, there's the Minnesota group and the Arizona group, and man, they just really just do not get along. And so the Minnesota group goes, hey, you guys are absolutely crazy putting everyone on these high-dose vasopressors. They're like, vasopressors, they actually cause splenic arterial constriction, decreases hepatic blood flow, and you're increasing intrasplenic lactate production. And they argue this actually decreases the metabolism of these drugs. So if you ingest a whole bunch of verapamil, you put someone on really high-dose vasopressors, is at least theoretically, is you're going to prolong out the effect of calcium channel blockers because you're going to decrease their metabolism. Now, they've tried to argue this, and unfortunately, they haven't really done a good job at proving this. This is Kristen Ergmiston. She was at Minnesota, and she is one of the biggest proponents about using high-dose insulin. And so let's talk about what is this high-dose insulin therapy, because this is really where I think non-toxicologists think that what we're doing in the tox world is just absolutely crazy, and I got to tell you guys, you're absolutely right, because this is absolutely crazy what we do. And so the whole point of high-dose insulin with your cardiovascular toxins is really trying to change myocardial energy consumption. Because what happens is when the heart gets stressed, is it tends to switch its energy source away from carbohydrates, such as glucose, to free fatty acids. And when you switch your energy source to free fatty acids, your ionotropy is actually just decreased. And so in the early 2000s, as some of the toxicologists, Jeff Klein did a lot of this initial work at Carolinas, is they took actually this high-dose insulin literature from the 50s that was actually looking at cardiogenic shock. And they said, hey, what if we actually tried to do this with calcium channel blockers and beta blockers? If we just force the cardiac myocytes, with high-dose insulin, it hits those GLUT1 receptors. Those GLUT1 receptors then increase glucose into the cardiac myocytes, thereby forcing the cardiac myocytes to switch their energy production from free fatty acids to glucose. And that's really all it is. And then they just started doing work and showing that we actually are seeing increased ionotropy, and it does tend to work well with beta blockers and calcium channel blockers. I'm going to go into some of that literature here in just a second. So there's really not that much, from the way that calcium channel blockers and beta blockers work versus the way that insulin help. There's not much of an overlap. And this is what really confused me when I was a resident learning about this, because I could never really figure out what beta blocker toxicity and calcium channel blocker toxicity has to do with high-dose insulin. And insert for that again, because there's really not much of an overlap. All high-dose insulin means is we're just switching that energy source to carbohydrates. Now, that's what I just said is 90% true. What is interesting with the calcium channel blockers is one of their mechanisms is they also do inhibit those GLUT1 receptors. So if you have verapamil, diltiazem around, is those GLUT1 receptors are not working nearly as well. So that is also telling the heart to switch over to free fatty acids. And so when we do use high-dose insulin, is we're trying to overcome the effect, particularly of verapamil and diltiazem. And so what does high-dose insulin mean? Just how high are you talking about? Well, we actually start with a 1 unit per kilogram bolus. If you think about it, that is 10 times the dose we actually give to a diabetic ketoacidosis patient. And that is just crazy. And then what we actually usually recommend is starting at 1 unit per kg per hour. Again, that is 10 times the starting rate that we use for most DKA type of patients. And then I'll go ahead and put someone on a D10 infusion. Usually, if we're starting high-dose insulin, they're getting a central line, and then we're getting at least Q30-minute AccuChecks. The glucose is actually not the big challenge for this. For me, it's really the potassium. Because when you use high-dose insulin, switching all that potassium intracellularly. So your whole body potassium is actually unchanged, but your serum potassium is decreased. And no one really knows with high-dose insulin, what should we target the potassium to? Because we know if we flood them with a whole bunch of potassium, we're increasing the total body burden. But we still know that when you talk about cardiovascular function, hypokalemia can be definitely detrimental. So I think most toxicologists will try to keep that potassium at least greater than 3. And one of the dangers about going too high is once you start pulling off the insulin, about 48 to 72 hours later, is almost all these patients become hyperkalemic because all that potassium that was shifted intracellularly is now coming back out of the cells. And so why is the glucose not that bad? Well, here is another PowerPoint animation, which if you're pretty astute, you'll notice this looks very similar to my cardiac animation, just because I said after making that cardiac one, I'd never make another PowerPoint animation again. This is your pancreatic beta islet cell. And what's really interesting about this is to release insulin is calcium also comes in through L-type calcium channels, acts as a second messenger, and it's ultimately how insulin is released. And so when you get a calcium channel blocker, it can inhibit these L-type calcium channels, and it actually prohibits or decreases the ability of your pancreatic beta islet cells to release insulin. And if you remember this case at the very beginning, her glucose is 241. I said, hey, that was interesting, because she doesn't have a history, at least that we knew of, a diabetes. And again, this is one of the ways that we'll try to tease out a beta blocker poisoning versus a calcium channel blocker poisoning. Because if you have a moderate severe calcium channel blocker poisoning, you're going to expect some type of inhibition of that pancreatic beta islet cell, and that glucose is always slightly elevated, either to the high 100s or to somewhere in the 200s, such as was her case. And it's another way that we'll try to tease out, is this a calcium channel blocker or is this a beta blocker poisoning in sort of the undifferentiated patients. But because of this is one of the reasons why when we start high-dose insulin for calcium channel blockers is we do have to often give supplemental dextrose. It's not nearly as much as you would think that we'd have to. And so usually just a D10 infusion will get most people through it. About a third of the time we will have to start a central line and go up to a either pushes of D50 or sometimes a D25 infusion as well. And again, complicating the or causing the hyperglycemia is these calcium channel blockers do directly inhibit GLUT1 receptors. Another reason is that by inhibiting GLUT1 receptors, your cells cannot pull glucose into the cell, so your serum glucose goes up, but actually your intracellular glucose is going down. So another benefit of high-dose insulin is really forcing those GLUT1 receptors saying, hey, you guys are being temperamental, please take all this glucose out of the serum into the cells, thereby increasing our myocardial function. And so again, let's look at some of the research that Minnesota's actually done. Again, this is Holger and Holger's first author and Kristen Ingerston, who are really big proponents of this. And I got to hand it to them, this is actually the protocol that they recommended. And what's really interesting is you see they're starting at 1 unit per kg push, and then they're starting at 1 unit per kg per hour. And what they're recommending, and this is just absolutely crazy, is they increase it by 1 unit per kg hour to up to 10 units per kg per hour. They'll titrate up. And if you think about that, is now 100 times the rate that we'd give to at least start a DKA patient at. And I can happily tell you that the Minnesota group now, this is an older recommendation, they are no longer recommending this. What they are now actually recommending is they start everyone up in Minnesota at 10 units per kg per hour, which is just absolutely crazy. And the only reason they actually stopped at 10 units per kg per hour is they just found out they cannot concentrate the insulin any more than that. To their credit, though, they have at least done the highest level of toxicology research you can do, which is really animal models, since IRBs generally don't like for us to intentionally poison humans. And on the left here, this is actually a Kaplan-Meier survival curve. They actually poisoned all these canines with verapamil. And this line up here just means the canines that got 10 units per kg per hour had 100% survivability, whereas this line right here is actually just a saline placebo bolus, 50% mortality. And if you actually tease this out, there's actually a clear dose relationship, that there was an increased survivability with 1 unit per kg per hour, then an increased survivability with 5 units per kg per hour, and then again 100% survivability with 10 units per kg per hour with these canines that are poisoned with verapamil. They also put a Swan-Ganz catheter in, and they measured cardiac output, and clearly with a 10 units per kg per hour, even in canines that are poisoned with verapamil, is they saw clear improvement of the cardiac output. One of the ways I will caution, though, is why do we not always go to high-dose insulin? Well, if you have a verapamil diazepam poison patient, it makes a lot of sense. Because really what you want to do is use that high-dose insulin, tell those cardiac myocytes, hey, switch over to using glucose, pump harder, increase my blood pressure. If I have, though, a calcium channel blocker, such as amlodipine, that's really just causing a lot of arterial dilation, and my diastolic is very low or undetectable, and I'm getting reflex tachycardia, it's very helpful if you can get emergent echo or put a ultrasound on the heart and just look at the cardiac function. Because that heart's really pumping with an amlodipine overdose, we'll say, hey, you know, it hasn't turned the corner. It's not causing direct cardiac myocyte inhibition. And actually doing high-dose insulin at that point could be detrimental, because one of the things that high-dose insulin will do is cause release of nitric oxide. Nitric oxide is another second messenger in my arteries that causes arterial dilation. So if I have an amlodipine or a dihydropyridine calcium channel blocker overdose, I'm saying, hey, you know, let's think twice before we start high-dose insulin in this patient. You know, really, let's look at their heart rate, let's look at their rhythm, and let's look at their echo. If their echo shows sort of hyperdynamic functioning, I would say, hey, you're probably going to worsen systemic vascular resistance by using high-dose insulin. Let's stick with calcium, let's stick with vasopressors. Whereas if I get a verapamil poison patient, diltiazem poison patient, or an amlodipine poison patient, echo shows, you know, a decreased left ventricular function, this is really, I think, where high-dose insulin is going to give you the most bang for your buck. And wrapping up here, I'm going to keep this right on time, is hemodialysis is really, you cannot pull off any of the calcium channel blockers. Briefly touched on atenolol. I mentioned earlier that it's just all case reports. Nadol and Cetol also do have low volume distributions. They have low protein binding, and they potentially could also be removed by hemodialysis. It's going to be complicated, though, that if you have a really sick poisoned patient with one of these substances, is you're really going to be stuck using CRT, and we just know CRT is in general not nearly as efficacious as pulling off drugs as hemodialysis is. Now, intravenous lipid emulsion therapy, this is something, again, that is incredibly experimental, very highly debated in the tox world. And what happens is, at least the very basic idea behind it is, if you get a lipophilic drug that's doing a lot of bad things, is interacting with cellular receptors, if you just give them a whole bunch of lipids, can you actually just form a myocele around it, basically like a big soap bubble. And so that lipophilic drug will actually be bound up by all the lipid molecules, and it won't be able to interact with sort of cellular receptors. And this is where high-dose lipid therapy or lipid emulsion therapy comes from. It's incredibly experimental. Its only FDA indication is really for local anesthetic toxicity. That being said, if we have a very lipophilic drug, and they're either having a cardiac arrest in front of us, or they're in that sort of pericardiac arrest, you're like, man, they are going down quickly. This is something where we would actually give a bolus of 1.5 mils per kg. And this is also something that, if you're ever considering using it, is I would highly encourage you to get on the phone, call your poison center, and ask to speak to your medical toxicologist. If you're calling from here, it's almost always myself that's on call. One of the reasons we don't recommend lipids for everything is, again, very experimental. The blood becomes incredibly viscous, increases your afterload. You can get pancreatitis with it. You can get ARDS with it. So we're really trying to limit it for just those patients that have pericardiac arrest. Really, we're just trying to throw the kitchen sink at them. And I am going to end with this slide right here. One of the other sort of last-ditch treatments that we'll consider for calcium channel blockers in particular is nitric oxide scavenger. And methylene blue can actually scavenge nitric oxide. Something that I'm actually doing some research myself on is using hydroxycobalamin, which is a cyanide antidote kit, can also sort of scavenge nitric oxide. By scavenging nitric oxide, you can actually cause arterial constriction, thereby increasing the systemic vascular resistance, something that we think actually works pretty well in your dihydropyridine overdose patients. And so just my summary slides here is, when you're giving fluids, you know, really, particularly if you have a calcium channel blocker that's having central pathophysiology, treat this as a cardiogenic shock patient. Do everything you can trying to limit the amount of fluids they're getting. Just remember that 22-year-old's chest x-ray, all those fluids are just going into her lungs. Glucagon, I'm a big fan of for beta blocker toxicity. Calcium is always my first go-to area, or my first go-to antidote. And then, this is just my summary. This is how I interpret all the literature. Every toxicologist or every intensivist that does this, I think, does this a little bit different. But for me, in my mind, beta blockers, absolutely, you can get really sick off of them. They're just not quite to the same catastrophic degree that calcium channel blockers are. So I'm going to try to limit just to 2 liters of fluid, calcium, glucagon, and I'm going to go very quickly to my vasopressors. I personally really like epinephrine just because you can overcome that beta-1 antagonism and then also cause increased arterial squeeze with the beta blockers. And with the calcium channel blockers, again, we're going to try to limit fluids. My thought is, there's that Minnesota model and then there's the Arizona model, and they talk about you have to do one or the other. And I think most sort of, if you will say moderate toxicologists, are like, well, why do we have to choose? Why can't we use a combination of vasopressors and high-dose insulin? And that's absolutely what I'll try. If I see a calcium channel blocker that's, again, causing symptoms of cardiogenic collapse, hypotension, bradydysrhythmias, decreased EF, is I'm going to start very early on with high-dose insulin, start a D10 drip, get Accu-Checks every 30 minutes, give calcium, but then I'll also go ahead and add epinephrine with it as well. And then if epinephrine or refractory to it, is then consider something like norepinephrine or phenylephrine that will just sort of increase my arterial squeeze. The calcium channel blocker patients, I didn't mention this earlier, but the calcium channel blockers tend to cross the blood-brain barrier. These patients can get very encephalopathic, very often massive overdoses, will become lethargic, lose their airway. So they often will need to be intubated, not only for airway protection, but really for that positive pressure ventilation, just because they have such a high likelihood of developing pulmonary edema. They almost always need central access. And then again, no one's ever studied this, but most toxicologists try really hard if we're doing high-dose insulin to keep that potassium greater than 3. Just understanding that usually 48 to 72 hours when these patients start improving is you start titrating off the insulin, is expect them to have some transient hyperkalemia. And I'm going to go ahead and end there. This is my email address. I'm incredibly passionate about this stuff. I like to talk about all the time. It's unfortunate we can't ask questions today, but I would really encourage anyone to ask me any questions or any thoughts, comments. I'll take criticism. And I would really encourage you guys to use a Poison Center, particularly for these sick cardiac toxidromes. And I think a lot of people don't want to wake us up when they're talking to the Poison Center, but by all means, if you get a sick cardiovascular toxidrome patient, tell the Poison Center to wake us up. I will try to be happy to talk to you, and I'll get over my grumpiness pretty quickly, even if it's at 3 a.m. All right, thank you so much.
Test, 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 test.
All right, I'm Graham McFarland. I'm currently an assistant professor of vascular surgery at UAB, and I appreciate the opportunity to speak today. This is a little bit outside of my wheelhouse, I guess, as far as talking the topic for today, but I've got some good slides to show you based off talking about direct oral anticoagulants and specifically managing the risk of those. So I have no financial disclosures. I do need to mention Dr. Obi, Andrea Obi. She's a vascular surgeon at Michigan who sent me the majority of these slides. This is kind of her thing. She researches risk factors and factors in development of DVT in critically ill patients. And she recently gave grand rounds at UAB, specifically speaking of the risk factors with the COVID pandemic, and it was really interesting. But the majority of these slides I have borrowed from her. So what are direct oral anticoagulants? Basically, historically everything, anybody that's been on anticoagulation has been on Coumadin, which inhibits, the synthesis of vitamin K dependent clotting factors, not necessarily directly inhibiting factors involved, or proteins involved in the coagulation cascade, which is where kind of the direct oral anticoagulants come in. They directly inhibit certain proteins within the coagulation cascade, specifically the the 10A inhibitors, which is apixaban, betrixaban, edoxaban, and rivaroxaban, and then dabigatran, which is a thrombin inhibitor. And we'll go into more details about those. The basic benefits of these, I think the big one for patients is that there's fixed dosing. There's no repetitive lab tests like you have to get with Coumadin, where you have to get your INR checked and the dose gets adjusted. The other big one for them is there's very few dietary interactions, as there are with Coumadin. They have rapid onset. You really don't have to bridge with these drugs. They usually take effect, with the first dose that they take, so there's no prolonged bridging as there is with Coumadin. And they have short half-lives, so when somebody needs surgery, you just hold the drug usually for 24 hours to 48 hours and they're good to go, as opposed to the standard 5 days with Coumadin. Now, that short half-life is good for that, but the short half-life also requires fairly strict adherence with these drugs. So patients that have a history of non-compliance with medications are not the patients you want to put on a DOAC, because missing one dose is a big deal now, because the half-life for some of these are 6 to 12 hours, and so missing a dose, they basically become subtherapeutic almost immediately. The other thing is they're very expensive. Historically, there's been a lack of reversal agents. That's recently been changed. We do have some reversal agents for these now. And then the majority of these have some form of renal excretion, and so patients with kidney disease, you have to be careful with how you prescribe these medications. So as I mentioned, the expense is kind of the big hindrance when you try to prescribe these medications to patients. This study looking at Medicare Part D data showed that the 30-day supply of a DOAC is 40 times greater than that for Coumadin. So it's not a trivial amount. Again, keep this in mind when prescribing to patients. We have the drug companies a lot of times will work with you now, and some insurance companies will work with you and give you a month or a year at little to no cost for the patient. The problem is when they fall off of that month or year, then they need to there needs to be a plan for where to go next. I recently had a patient that had a IVC thrombus with an old filter in. The filter was removed, and then we did a bunch of thrombectomy, and to protect him from a PE during that operation, we put a suprarenal filter in, so above the renal veins, put him on Xarelto, sent him home. He was supposed to come back within a month to get that filter taken out and then work with his anticoagulation. He never came back, and when he ran out of the medication, couldn't afford it, stopped taking it, then he thrombosed his entire IVC up to the renal veins and had a fairly severe kidney injury. Luckily, we were able to recover that. But again, it's not something to just, it's okay, here's your 1 month, we'll see you later kind of thing. You need to have a plan for long-term adherence. That being said, things are really moving in the direction of the so-called DOAC era, with warfarin in the 1950s up until just recently has been kind of the primary go-to drug. With warfarin, there's really no low dose prescription. It's full dose, kind of all or nothing. So for patients with VTE or with AFib, INR of 2 to 3, those with on it for an aortic valve, 2.5 to 3.5. So there's really no low dose option. And then the bridging and the prophylaxis with low molecular weight heparin or unfractionated heparin both require injections and are not oral medications. Moving into the DOAC era, you have the option of a full dose, which is recommended for non-valvular atrial fibrillation and for treatment of venous thromboembolism. But then you also have the reduced lower dose, which is indicated for prophylaxis of DVTs and also reduction of major adverse coronary events post-surgery or after treatment of a DVT. And then, as I mentioned, we do have the approval of some reversal agents for both dabigatran, the thrombin inhibitor, and then the 10A inhibitors as well. This data from 2015 just shows the trend, and so as I mentioned, despite the obstacles with cost and some of the other issues with renal disease and the likes, the use of DOACs is increasing, whereas the use of warfarin is decreasing, and this again was from 2015, so this is even more significant at this point. So currently we have 5 DOACs that are approved in the U.S. The 2 most common at this time, rivaroxaban or Xarelto, and apixaban or Eliquis. Dabigatran and Pradaxa is also relatively commonly used, but again, by far the 2 most common are the rivaroxaban and apixaban, and their approved indications, you can see in this chart here, are for non-valvular atrial fibrillation, acute venous thromboembolism, secondary prevention of venous thromboembolism, prevention of ETE and with orthopedic surgery, and then MACE or MAL reduction, as well as venous thromboembolism prevention in acutely ill patients. As with anything in medicine, you have your on-label use, or in vascular surgery, we talk about the IFU, instructions for use all the time, whereas a lot of times we do certain things off-label, and with these DOACs, there's a lot of off-label use going on. There's a lot of good studies that have come out recently supporting the off-label use of these medications. And specifically, as a vascular surgeon, I'll focus kind of primarily on the peripheral disease. So with superficial venous thrombosis, post-thrombotic syndrome after DVT, and then the MAL and MACE, as well as HIT and postoperative MI. So for the SVT, or superficial thrombosis, the SURPRISE trial recently compared rivaroxaban to fondaparinux, which is kind of the standard of care now based off the Callisto trial. And what this was is a prospective randomized open label trial looking at high-risk patients, so high-risk superficial venous thromboembolism, which is described as 5 centimeter in length or greater SVT above the knee, with one additional risk factor based off age, male sex, previous history of DVT, cancer, autoimmune disease, or thrombosis of non-varicose veins. And what it showed was that rivaroxaban was not inferior to fondaparinux, and then again has the benefit of being an oral agent and not requiring injection. I'll spend a little more time on this COMPASS trial, because this is a big deal and something that's really changing the way we treat patients. And specifically, I'm going to focus on the PAD, or peripheral arterial disease, component of that study. And what this was basically a cohort of patients with PAD, so either asymptomatic PAD based off of ABIs or other hard evidence of peripheral arterial disease, symptomatic PAD, and then patients with asymptomatic or symptomatic carotid disease. And you can see the breakdown there. And what they did is they compared low dose, so 2.5 milligrams of rivaroxaban twice daily with aspirin, versus 5 milligrams, this is a typo here, 5 milligrams of rivaroxaban twice daily on its own versus aspirin alone. And they looked at kind of the primary outcome was a combined outcome of acute limb ischemia, chronic limb ischemia, amputation, and then they also combined that with coronary events, so stroke, heart attack, or cardiovascular death. And then looking at the primary PAD outcomes, they actually stopped this trial early because the outcomes were significantly in favor of the low-dose rivaroxaban with aspirin as compared to aspirin alone. You can see here that almost half of patients on the rivaroxaban low dose had the combined event of acute limb ischemia, chronic limb ischemia, or amputation compared to the aspirin alone group. So rather significant findings. This is primarily due to reduction in acute limb ischemia and amputation as opposed to the chronic limb ischemia. So those were kind of the 2 primary things that affected the change. And what they showed with the combined limb events and coronary events, it was overall about a 3% risk reduction, absolute risk reduction, favoring the low-dose rivaroxaban. along with aspirin. Just further evidence or another diagram showing these findings. And then it's worth mentioning that the low-dose rivaroxaban group did have an increased rate of bleeding, as did the higher-dose rivaroxaban alone group. But when combining basically the net clinical benefit versus the risk of bleeding, you still see about a 3% benefit to the low-dose rivaroxaban and aspirin group. So I've started giving this to certain patients, patients that I know are compliant with medications and have symptomatic PAD primarily in my practice. I've started offering the low-dose rivaroxaban group. There's still the issues with getting it paid for. It's not necessarily just because it's indicated now doesn't necessarily mean it's any cheaper. So all those factors have to be taken into account. This Voyager PAD trial, so actually when I put this talk together, I was supposed to give this in March, and then the whole COVID thing happened and it postponed it. So the results of this trial were not out at that time. I actually changed the slide, but this is not the, I guess, most up-to-date version of this talk. But basically it's a similar study to the COMPASS trial, but this looked at patients that were within 10 days of peripheral revascularization, so stenting or bypass, and compared the low-dose rivaroxaban and aspirin to a placebo and aspirin. And again, I don't have the results on here, but they were very similar in that patients with the low-dose rivaroxaban had better outcomes with regards to revascularization durability, as well as lower risk of coronary events long-term. Briefly, just in the interest of time, post-thrombotic syndrome, so patients that have had a DVT, that have a risk of developing post-thrombotic syndrome. There's not a lot of data on this yet. There's more to be done, but what we've seen is that at least in this market scan data from 2012 to 2015, looking at about 37,000 patients, patients treated with rivaroxaban as opposed to Coumadin do have a lower risk of developing post-thrombotic syndrome, and in particular post-thrombotic syndrome with the development of a venous ulcer. So again, promising data there. Patients with heparin-induced thrombocytopenia, again, difficult thing to study. There's not a lot out there on this yet, but just because it's such a low prevalence, it's going to be hard to perform, randomized controlled trials. So a lot of this is going to have to come from retrospective or registry data. But the rationale behind using a DOAC in this situation is that the PF4, what the HIT antibodies essentially attack, is not DOACs do not react with this, and so should theoretically be able to be used and not have issues with heparin-induced thrombocytopenia. There's been one prospective study on this, 2 case series and multiple case reports for a total of 56 patients, and overall the data is pretty promising there. And then finally, looking at the use of DOACs to reduce postoperative myocardial injury, this MANAGE trial, which has some issues, but overall looked at patients between 45 and 64 years of age that essentially developed a postoperative myocardial injury, either based off asymptomatic troponin elevations within 48 hours of surgery or symptomatic myocardial infarction. They were randomized to dabigatran versus placebo for up to 2 years. And what they found was that overall there was a benefit. So patients with the primary efficacy outcome of vascular mortality, non-fatal MI, non-hemorrhagic stroke, peripheral arterial thrombosis, or symptomatic venous thromboembolism, the risk was decreased 11% of patients with dabigatran and 15% those with placebo, for a hazard ratio of 0.72. And interestingly, the risk of major life-threatening bleeding was equivalent between the two groups. So there's some promise there. Again, I mentioned there's some issues with this. 40% of the patients discontinued the study drug early, and only 70% were on statin and 60% were on antiplatelets, which are pretty much indicated across the board in this patient population. So conclusions regarding kind of the off-label use of these DOACs. It seems that rivaroxaban is safe and has a growing role in the treatment of SVT. Low-dose rivaroxaban is likely beneficial for the prevention of major adverse limb events in the subset of patients with PAD, as well as those following revascularization based off the recently published Voyager data. Therapeutic anticoagulation following high-risk peripheral arterial procedures or use of DOACs following the diagnosis of HIT, again, is going to be tough to study. We're going to require more retrospective and registry data there to prove whether or not they're useful. And then the use of dabigatran for patients suffering MI appears to be beneficial, but again requires more substantial data there to make that standard of care. So with all that in mind, the current recommendation, at least based off the CHEST guidelines from 2016, is that in patients with DVT of the leg or pulmonary embolus with no evidence of cancer, as the kind of first line long-term treatment for at least the first 3 months, suggested that the DOACs are more beneficial than the vitamin K antagonists or Coumadin. And that's based off of several studies that are kind of summarized here. The Amplify and the Einstein study is probably the most well-known, but basically across the board, of patients with primary DVT or PE, the risk of recurrent DVT or DVT-related death is decreased or improved with the use of a DOAC over Coumadin. So this really should be first-line therapy if possible. When prescribing these medications, several things again that we've kind of touched on to keep in mind. It is not indicated for patients with mechanical valves, so Coumadin is still standard of care there. Again, cost is a big deal, and you really have to assess the ability of the patient to afford it and how long it's going to be covered effectively by insurance. There's some data out there that suggests not to use this in antiphospholipid antibody syndrome. And then also for initial therapy in cancer patients, Lovenox is really the recommended treatment there. And there's still, the verdict's still out on DOAC therapy. Important things to keep in mind with drug dosing. I'm going to kind of skip through this and go to this slide. As I mentioned before, renal excretion is kind of the primary mode for these drugs. In particular, dabigatran, 80% of that drug is cleared through the kidneys. Apixaban, only 25%. And so in patients with poor kidney function, apixaban is really the treatment of choice. Now that's, keep in mind that that's only for patients up to stage 4 kidney disease. Patients with creatinine clearance less than 15, you really should probably avoid these drugs for the time being. But there's currently no dose adjustment indicated for apixaban, rivaroxaban, dabigatran, others. You know, patients that have poor kidney function, there are some dose adjustments there to keep in mind. With that being said, there has been several studies, and this is a meta-analysis kind of proving that the benefits of DOACs in patients with stage 3 to stage 5 kidney disease, looking at this 45 trials of almost 35 or a little over 34,000 patients, kind of showed similar benefits to DOACs, as I mentioned earlier. Basically, in patients with AFib, reduced embolic stroke or stroke events, and hemorrhagic stroke as compared to Coumadin. Pretty significant findings there. And they seem to be lower risk of major bleeding overall when compared to Coumadin, despite the fact that most of them are cleared via the kidneys. I've kind of touched on all this. So again, one of the bigger benefits of DOACs is that it doesn't require the frequent monitoring like it does with Coumadin. But there are certain times when monitoring these drugs is important. So specifically patients that are bleeding, whether that's major or minor bleeding, you know, or just a standard GI bleed. Generally patients that require surgery more urgently, so that you can't stop the drug a full 24 to 48 hours before surgery. Patients with extremes in body weight, so patients that are extremely thin, extremely obese, those with declining renal function. If you think you need to reverse the DOAC, usually kind of falls into the urgent surgery or bleeding category if there's a suspected overdose, and then if you're concerned about compliance in a patient that's been prescribed a DOAC. Generally, for the 10A inhibitors, so rivaroxaban, apixaban, anti-10A activity is the test of choice, and that's pretty commonly available kind of across the board. The thrombin time for dabigatran is the test of choice, which is, I guess, less commonly ordered. There are Other things you can look at, prolonged PTT can sometimes indicate that the patient has clinically significant dabigatran or even anti-10A or 10A inhibitor levels. A negative anti-10A basically tells you that the patient's not been taking the drug for the 10A levels, or normal PTT can also kind of point you in that direction. Again, title of the talk, Managing the Risk. So what are the risks of DOACs or all blood thinners alike? And the main one to talk about is obviously bleeding. And so, how do we approach patients that are therapeutically anticoagulated on these DOACs that have active bleeding issues or need an urgent surgery for some other issue? I will say that, again, as I've shown before, the risk of major bleeding is lower in this patient population as compared to those on Coumadin, but it's still a significant risk factor. And when you break it down by types of bleeding, whether it's intracranial, fatal bleeding, major GI bleeding, again, all in favor of DOACs as compared to the historic therapy of Coumadin. So kind of to discuss this and how I would approach this as a vascular surgeon, I feel like it's best to present it in case presentation. So I've got two cases, one with a patient on Coumadin, just to kind of show you, how we would treat that, and then how it differs for a patient that's on a DOAC. So the first case is an 83-year-old female with a history of atrial fibrillation and severe cardiac disease with an EF of 10%, who's on Coumadin for her AFib that presents with back pain and a drop of her hematocrit, and notable surgical history of an aortobifemoral bypass. If you look at the image over here on the right, you can see it looks like there's probably a proximal dehiscence of the proximal anastomosis. I'll just kind of full disclosure, this is not my patient. This was a patient I borrowed from Dr. Obi. We can go down the list of reasons why this may happen remotely. Infection has to be high on the risk, so the treatment for this has its issues, but we're not focusing on that today. We're focusing on how to treat this particular patient with regards to her blood thinner. So she's urgently booked for an EVAR cuff or an endovascular repair of this, where they basically seal across the dehiscence there. But unfortunately, our INR was 9.2. So obviously not an ideal situation. So what would be the optimal reversal strategy for this patient? Is it FFP to reverse the INR? Is it prothrombin complex concentrate, or PCC? Is it a combination of FFP and vitamin K, or a combination of PCC and vitamin K? And so we'll kind of go through this and get our answer here. So, when you see a patient that is on an anticoagulant and has a bleeding issue or has an issue that needs urgent surgery, there's kind of a stepwise fashion in how you assess these patients. First, you need to know how severe is the bleeding. Is it major bleeding, life-threatening at the time, or is it more minor, like a minor GI bleed that isn't necessarily busting through the doors to try and fix this problem? You also want to know the anticoagulation status, and we'll go into more detail with this, but specifically the drug they're on, the dose, and whether or not they've been compliant, and then also the indication they have to be on anticoagulation. So again, how fast are they bleeding? What is the rate of hemorrhage? The location, is it intracranial, or is it in a compartment that makes things a little more urgent? Is it a retroperitoneal bleed? Is it GI? Where is the bleed, and how are you planning to fix it? Again, with the drug, the dosing, the last time they took the drug, and then whether or not there's any renal or liver impairment that may affect how this drug is, how effective the anticoagulant is. Then other medications they may be on that may increase their risk of bleeding, specifically aspirin and Plavix in this patient population. And so to kind of determine and what's really defined the current standard of care, there was a recently well done study looking at 181 patients. It was published in The Lancet in 2015 that essentially compared PCC plus vitamin K to FFP and vitamin K. And what they determined is that the average time to end of infusion was much faster, 20.9 minutes as compared to 140 minutes. In favor of PCC, which led to an earlier time to start of surgery, 3.6 hours as compared to 8.5 hours, and ultimately a quicker time to end of surgery, 8.2 hours versus 11.1 hours, again, all in favor of the PCC arm. And you can see that PCC is just more effective in general for INR reversal as compared to FFP, again, from the same study out of Lancet. things to keep in mind when using PCC is that you need to kind of know the dosing. And then also there's a key allergy that you need to check for when prescribing this medication. The standard dosing is 50 units per kilogram, and I'll kind of show you a protocol to use, but the max dose that you would start with is 50 units per kilogram plus 10 milligrams of IV vitamin K. And then the allergy to test for is the heparin allergy. So patients that have a history of HIT, you need to be careful using PCC because most of it has heparin with it to keep it from coagulating in the bag. So as I mentioned, this is a protocol that they use at Michigan, and we use something similar to this that bases the dose of PCC off of how elevated the INR is. And so patients with an INR of 4 or greater, 6 or greater usually gets the full dose of 50 units per kilogram versus somebody with 4 to 6, 35 units per kilogram, and then down the line there. It's important. Remember the simple things. Obviously hold their warfarin if they're having a bleeding issue, especially if it's moderate to severe. Supportive care, so if they're in hemorrhagic shock, you obviously want to resuscitate them with volume, and you can use FFP as volume in this patient population along with the PCC if needed to provide kind of a longer term reversal of the INR. But again, based off the INR is kind of how we prescribe the PCC, and obviously the vitamin K dose is kind of standard across the board. There are different types of PCC. Kcentra is probably the most commonly used, but there's 4F PCC and 3F PCC, and basically 3F can be made into 4F just by adding some FFP to the bag. But again, important to keep in mind about the heparin allergy. You really can't overstate that. So obviously for this patient, as I hopefully have just shown you, the optimal strategy for reversal is PCC plus IV vitamin K. And this is her repair. You can kind of see she had that pseudoaneurysm up here at the proximal anastomosis, and then an effective seal with the EVAR cuff. Supposedly in this case it was not quite as straightforward as they had hoped. It took longer. There was an iliac rupture requiring a stent, and took several hours to fix, but ultimately fixed successfully. Estimated blood loss was 500 ml, and she was given 2 units of red blood cells in the OR. Basically high fives all around, saved her life, theoretically. So, but going on with the same patient, you go to pull the sheaths, and there's excessive bleeding from around the sheath and in the soft tissue. And so what could be happening here? You theoretically have reversed the patient's coagulopathy with PCC, got the INR down to normal. So what could be happening here? Is the patient DIC? Did they have a heparin allergy and are now on heparin-induced thrombocytopenia? Was the PCC inadequately dosed, or do they have some sort of transfusion coagulopathy? For those of you who have used PCC, you know that there's a half-life that's important to pay attention to, and that essentially the PCC in this case, because it was prolonged, is likely worn off. And so for PCC, the effectiveness of this drug is based off the shortest half-life, which just happens to be factor 7, which is approximately 6 hours. And so if you're still operating at that time point, it's important to consider rechecking the coagulation parameters and potentially redosing. But the danger of this drug is that when you give more, this can lead to an accumulation of thrombin, which has a half-life of 60 to 72 hours, that is also in PCC, and it can ultimately lead to vessel and graft thrombosis, which is a whole another set of problems in its own right. So that's where giving FFP, especially in somebody that needs volume, is a good idea in this patient population, because you can get more long-term reversal of the INR. And so in this case, the PCC was inadequately dosed and needed to be redosed, or FFP needed to be given. So then looking at a patient with another bleeding complication that's on dabigatran, or one of the DOACs. This is a 62-year-old male with a history of atrial fibrillation that is on Pradaxa, took the drug 2 hours ago, and then got into a car wreck and presented with hypotension, blood pressure in the 50s to 70s, and systolic blood pressure in the 50s to 70s, and a CT scan showing basically that he had a ruptured aorta along with his recent MVC. And so for a patient that recently took dabigatran, what is the reversal strategy? Is it PCC plus vitamin K? Is it and I always mispronounce this, so I'm just going to call it Praxbine, which is the common name used for it. Dialysis, or the Anexa, which is the which is the 10A inhibitor reversal agent. And so, again, it's important to start with, how significantly is the patient bleeding, how severe is the issue, how urgent does all this need to be. But then when you move on to assessing the anticoagulation, it's important to know which drug they took and when they last took it. And you can see the half-lives differ to as short as 5 to 9 hours for rivaroxaban to as long as 19 to 27 hours for Betrixaban, or in this case, 12 to 17 hours for dabigatran. So since he just took it 2 hours ago, it should theoretically be in full effect. Again, important to remember renal and hepatic function assessment in these patients, as most of these drugs have a combination of excretion, but in dabigatran, again, 80 to 85% renal excretion, which is what this patient is on. The ability to test for the effectiveness of the DOAC will be kind of institutional dependent. As we mentioned, anti-factor 10A testing is ideally calibrated to the specific anti-factor 10A agent being used, and then thrombin time for the dabigatran is the most important test for this patient and the drug he's on. The TEG study is commonly used. That's what we use in a lot of our critical patients, specifically in the trauma population. There's really been no data to support the use of TEG in DOACs. But just to kind of touch on that and how it theoretically should be able to be used, the idea behind the TEG is that it allows you to resuscitate the patient specifically to what they're lacking based off of which of these is prolonged or shortened. Kind of indicates which agent should be used. Let me just see if this works. Yeah. And so, the R time really looks at clot initiation, K time, and the alpha angle tell you kind of what your circulating fibrinogen levels are. The time from R to the max amplitude gives you your clot strength, and the max amplitude gives you clot stability. And based off of which of those are abnormal, can kind of indicate which products would be most effective in reversing the anticoagulation. Excuse me. And this, not specifically looking at DOACs, but this kind of gives you the reasoning behind the use of the TEG and why it works, or that it does work. This just looked at 111 patients undergoing massive transfusion protocol, guided by either the TEG study or the conventional monitoring with INR and PTT, and basically the survival was significantly greater in the group that underwent guided transfusion based off the TEG study, as opposed to the conventional monitoring. So as I mentioned, we do have available reversal agents, which most facilities hopefully have at this point. So for dabigatran, it's the Praxbind, and for the anti-10As, it's the Anexa, both of which are approved. There's a Siraparantag that's currently being evaluated and will likely be available hopefully in the near future. But for this patient in particular, these Praxbind, is the agent of choice. And this study that was published in 2017 in the New England Journal of Medicine, looking at 2 cohorts, those with serious bleeding and those that require an emergent procedure, both treated with 2.5 grams of 2 boluses each within 15 minutes of each other. What they found was significant, basically the effectiveness of the drug. So the drug was 100% effective in reversing the anticoagulant effect of dabigatran. With the patients in the bleeding cohort had a median time to bleeding cessation of 2.5 hours, and then those needing an urgent procedure were able to be in the OR on average within an hour and a half. If all else fails and you don't have the drug, always keep in mind, specifically with dabigatran, that dialysis can clear this drug rather effectively if needed. So for urgent reversal of the 10A inhibitors, I've mentioned the Anexa, which was recently approved in 2018. This one's not quite as effective as Praxbind is at reversing dabigatran, but effective nonetheless. And so what they were able to show is that overall you did have thrombin generation restored in 96% of patients getting Anexa versus just 7% in the placebo group. There are some thromboembolic events that do happen in up to 18% of patients. There were 15% of these patients, or 10 patients, that died in this study. Overall, looking at the effectiveness of Anexa to PCC, which would be kind of the next line of therapy, the overall effectiveness is relatively similar, 81% for PCC, 79% for Anexa. But again, these are two different studies, so they have to be, that has to be taken into account when comparing them. But there were more thrombotic events with the Anaxa group actually, as opposed to the PCC. But I've already kind of talked to you about the risk of thrombosis with the PCC group. I'm just going to skip through this slide and apologize. So, as hopefully I've shown you in this patient, the Praxbind is really the agent of choice. 2.5 grams given in 2 separate boluses, 15 minutes apart, is generally how that would work, and hopefully get the patient off to the OR ASAP. So in conclusion, the DOACs are kind of around to stay, and in all likelihood they will become much more common as further indications are discovered and proven to be effective. And understanding the monitoring of these drugs, when they need to be monitored, and ultimately how to urgently monitor them or assess their effectiveness in a patient that needs an urgent procedure or is actively bleeding, and then knowing the major reversal agents and when to use them is important to know, basically for anybody across the board, as the majority of patients, or the significant number of patients that you'll see, regardless of which practice in, will likely be on these agents. And that's all I have.
If a patient has, the mechanical valve, you don't recommend, DOAC anymore?
Yeah, so it's still actually contraindicated to use a DOAC in a mechanical valve. There was one of the earlier studies looking at these showed an increased risk of thrombotic events in that particular patient population. So Coumadin is still a therapy of choice there. All right. Okay, thank you.
Thank you.